that everyone see that?
Yep, can see it.
Brilliant.
Good.
Thank you. Yeah, thank you for that introduction, Alison, and thanks for having me, everyone, for this talk today. As Alison said, I'm going to be presenting on some of my insights from attending the British Neuroscience Festival this year, which was back in April down on the docks in Liverpool. So I'm going to split this talk into two sections. I'm firstly going to present the poster that I took to the BNF this year on behalf of PMP and present the results of that. And I'm then going to move on to presenting a bit more of the wider pain research, which was present at the festival this year, just to give us kind of a flavour of what's going on in the world of neuroscience and pain at the moment. So to start, the poster that I took to the BNF this year was one of our departmental audits, and it was titled, "Does a Pain Management Programme Meet the Needs of Chronic Pain Patients with Functional Neurological Disorder?" This audit was done by Jen Morris, Matt, Nathan, Jack and Katie here at PMP, and I put together the poster and took it to the festival on behalf of those clinicians. So the background of this audit, our most recent departmental audit, which was from 2022 to 2024, showed that 8% of our patients referred to PMP have a comorbid diagnosis of FND as well. Now, interestingly, a recent 2024 paper suggests that the actual incidence rate could be much higher, with up to 55% of those with FND experiencing comorbid chronic pain. Now, it's important to note here that we are only seeing patients at PMP where chronic pain is a presenting problem. So this could contribute to our lower incidence rates within our department. However, this is a presentation that we are likely to see within clinic increasingly over the coming years. So while both FND and chronic pain impact quality of life, together they create unique complexities for treatment which aren't completely understood. So this audit was produced with the aim of understanding these patients' treatment pathways, the support required by these patients, and their outcomes as well. So to achieve this, we extracted data from 2014 to 2024 for all FND patients referred to PMP. For those patients, we extracted their demographic data and then outcomes of pain intensity, pain catastrophizing, mood, physical functioning, and goal progress. And that was extracted at their baseline, reassessment after PMP, and also follow-up where that data was available. For those outcomes, we calculated effect sizes using Cohen's d, and then also benchmark those effect sizes against the minimum effect expected in a randomized control trial, PMP. And that was done for all those outcomes apart from goal progress, which wasn't included in the RCT. So the first aim of this audit was to look at these patients' treatment pathways, and we've got a demonstration of these on the screen here. So what we can see is in that 10-year period of the audit, we assessed 60 patients with comorbid FND and chronic pain. Of those 60 patients initially assessed, 28 were found suitable for a pain management programme. However, 24 required preparation before coming on that PMP. At the time of audit completion, 15 of those patients had completed a PMP. 11 were still in active treatment and 2 had dropped out of a PMP. Interestingly, 32 of the initial patients assessed were deemed not suitable for PMP, and there were a variety of reasons for this, but the most predominant reason was that pain was not the primary symptom impacting quality of life. And in those cases, more often than not, it was that the FND symptoms, for example, deconditioning or fatigue, particularly related to the FND, was more impactful for that patient rather than their chronic pain. Other reasons for not being suitable for a pain management programme included a lack of diagnosis understanding or an unreadiness for a self-management approach. Now, the second aspect that this audit wanted to look at was the extra support requirements of these patients. We can already see that a lot of these patients required preparation before attending a pain management programme, and that was with at least one discipline. And in fact, some of those patients required prep with more than one discipline as well. Now, on the pain management programme itself, we provide extra support sessions with clinicians if required. So this audit found that 6 of the 28 patients deemed suitable for PMP required that extra support with a clinical psychologist, and 7 required extra support with a physiotherapist while they were on the programme. Now, in addition, some of these patients experience functional seizures, and 3 of the patients within that group required a seizure plan for their time on the PMP. However, at the time of audit completion, none of those patients had had a seizure whilst on the PMP. Now, in terms of these patients' outcomes, we calculated the effect sizes for the patients that had completed the PMP. So that was for 15 patients. And we found medium to large effect sizes for all the outcomes extracted for those patients, which suggests that attending the PMP was effective at improving those outcomes for that group of patients. And further evidence for that claim was found in that all those effect sizes surpassed the benchmark, which is in the randomized control trial I mentioned earlier. So from those outcomes, we can assume that the PMP was effective at improving all outcomes for patients with FND and chronic pain, but where pain was the primary symptom affecting quality of life at the time of referral, and only for those patients who had completed a programme. So, in conclusion, from this audit, we have seen that the treatment pathway is dependent on the prominent symptom and also the ability to engage in the PMP. And what's unique for this patient group is that often the FND is more of the prominent symptom rather than the chronic pain, and deciding for the at assessment which is the more prominent symptom more likely determine the pathway for the patient. We also saw that of those patients deemed suitable for PMP, extra support requirements were common, and in particular that was preparation prior to coming on the pain management programme. From the outcomes of the group that had finished a PMP, we can see that the treatment was effective for those who have FND alongside chronic pain to manage likely the pain symptoms for those patients. And therefore, we can suggest that patients who have comorbid chronic pain and FND may benefit from PMP input. So really positive results from that audit there for that unique group of patients that have FND and chronic pain. I had really interesting feedback from this poster at the festival this year. I wanted to pose some of the common questions to the group here today, and I'd be interested to see if anyone has any ideas on these or whether they pose any possible future directions for this group of patients. So the first question I got asked a lot was what happens to the patients that are deemed unsuitable after their initial PMP assessment. I did a bit of digging into this myself, and I found that 26 of the 32 patients deemed unsuitable for PMP assessment were immediately discharged. So that was 81% of those patients not deemed suitable. I did see that 6 of the patients deemed unsuitable were put forward for outpatient treatment here at PMP. However, of those 6, 4 were discharged following only 1 or 2 outpatient appointments. And the reasons for discharge were similar to the reasons for being discharged immediately after assessment, with the most predominant reason, again, being more impactful FND symptoms than chronic pain. The second question I got asked at the festival was, is there a role for PMP, or would PMP be effective for patients with comorbid FND and chronic pain, but who experience more impactful FND symptoms? So obviously that was the majority of patients that were found unsuitable for PMP. And I think this question was particularly asked in the context of the idea that FND services are often very specialised and may have long waiting lists. So is there possibly a role for our service while that patient might be on that waiting list for their FND treatment in terms of addressing the chronic pain? So yeah, interested to hear anyone's thoughts on that at the end of the presentation. So I'm now going to move on to the wider pain research, which was at the British Neuroscience Festival this year. Now, for this research, I want to just give a really kind of brief overview of lots of the kind of projects that were at the conference. And my aim with this is just really to inspire kind of further reading or a bit of curiosity into the updates in the neuroscience of pain. If I'm presenting anyone's research who's present on the call today, I'm really open to feedback at the end, and I hope I've interpreted it all correctly. But the first talk I want to mention today is the Walton Centre Sutcliffe Kerr meeting, which took place as part of the British Neuroscience Festival this year. And the first really interesting pain-related talk in this was the latest research in the neurophysiology of chronic pain, which was given by Dr. Andrew Marshall, who's one of the neurophysiologists here at the Walton Centre. Dr. Marshall has been looking at peripheral nervous system function in chronic pain, and the first finding he spoke about in this talk was altered nervous system function in mice injected with serum from fibromyalgia patients. And in this context, serum refers to immunoglobulin, so that's antibodies from fibromyalgia patients. And specifically what Dr. Marshall has found in terms of altered nervous system function is an increased response to cold stimuli in these mice. And that's actually an increased proportion of the peripheral nerve fibers that are responding to those cold stimuli. So this is a really interesting finding in that it could be an avenue of explaining why so many of our fibromyalgia patients present with temperature sensitivity, say, and maybe possibly one of the mechanisms behind that. A second really interesting finding that Dr. Marshall presented was abnormalities in peripheral nerve function in humans with fibromyalgia. And he demonstrated this using a technique called microneurography. And he suggested that these abnormalities could be a possible mechanism of the tingling or numbness described by patients with fibromyalgia. So these findings together, Dr. Marshall is suggesting that the positive sensory phenomena of chronic pain, so that's abnormal sensations that occur without stimulation, could possibly be explained by peripheral neurobiology. So kind of the ideas of looking further than just the central nervous system when we explain the mechanisms of chronic pain, and looking towards the peripheral nervous system now as well to explain some of these symptoms that our patients describe. The second talk that I want to present from the Sutcliffe Kerr meeting was Professor Gobel's updates on the autoimmune biology of chronic primary pain. Now, I'm sure many of us have heard of Professor Gobel's experiments with mice and that transferring the immunoglobulin from fibromyalgia patients to mice results in increased pain sensitivity in the mice. What Professor Gobel presented at this year's Sutcliffe Kerr meeting was a similar finding from CRPS patients. So Dr. Gobel has found that trauma to a limb following the transfer of antibodies from patients with CRPS induces CRPS symptoms in mice. And what that looks like is a reduction of force needed to create a pain response in the paw that's experienced the trauma in those mice. So that's really similar to those fibromyalgia findings and adds weight to the idea that antibodies may have a role in chronic primary pain. And what Professor Gobel is suggesting is that antibodies may have function modifying effects without tissue destruction. So this could be a possible side effect of our sophisticated immune system and points again further to looking further than just the central nervous system when trying to explain the mechanisms of chronic pain, and more research being needed into the role of antibodies and autoimmune biology in these conditions. So I'm now going to move on to a really interesting seminar I attended at the festival this year, which was titled Interdisciplinary Neuroscientific Approaches to Understanding Complex Chronic Pain. And this was a fascinating talk, which went all the way from the autoimmune biology again, all the way up to social neuroscience, so kind of expanding out as we went along. So to give really brief overviews again of these talks, we first heard from Dr. David Anderson, who collaborates with Professor Professor Gobel here at the Walton Centre, and he elaborated a bit further on the research into the passive transfer of fibromyalgia symptoms from patients to mice. As I said before, we've seen that transferring antibodies from these patients to the mice results in increased mechanical and cold sensitivity in those mice, so suggestive of fibromyalgia symptoms. Interestingly, removing those antibodies from the mice appears to reverse those sensitivities towards those stimuli. So Dr. Anderson has built on this idea and has actually performed plasma exchange between 2 fibromyalgia patients and 2 healthy controls. And that plasma exchange has resulted in a significant increase in quality of life and a decrease in the pain experience for those fibromyalgia patients. So again, adding to the idea of a possible role of antibodies in chronic pain, and also kind of starting to look at possible kind of interventions in that area as well. From there, we heard from Dr. Nick Fallon, who presented on peripheral central neuroimaging to investigate mechanisms of fibromyalgia syndrome. And this is again building on the idea that we might need to look beyond the central nervous system for chronic pain mechanisms. And this study is based on the fact that for fibromyalgia, there is a lack of clear pathophysiology from MRI scans of fibromyalgia patients. But that Dr. Fallon has started to see that brain structure exhibits relationships to markers of peripheral nervous system integrity. So this study is still in its very early stages and requires further investigation, but again, widening the scope beyond the central nervous system. We next heard from Barbara Silva Pasaduro, who presented her quantitative EEG findings in long COVID and similar conditions. And what was really interesting from this talk was that Barbara has found differences in the alpha frequency, so that's found on the EEG, in long COVID patients and healthy controls. But these differences are really similar to differences seen in fibromyalgia patients and chronic fatigue syndrome patients. So the idea that these conditions could have quite overlapping mechanisms and might be better understood in terms of symptom prevalence rather than those specific condition labels. And then finally, in this seminar, we heard from Dr. Charlotte Krahe, who presented social neuroscience approaches to understanding the experiences of interpersonal interactions in chronic pain. And some of these studies have been co-supervised here by our team at the Walton Centre. And what Dr. Krahe has now found is that there is a demonstrated negative bias on interpretation of healthcare interactions in fibromyalgia patients, even when you control for their anxiety or depression. And kind of theorizing from social neuroscience on why that might be, ideas that interpersonal interactions begin way back in infanthood and continue to develop all the way into adulthood. And they influence not only our interactions with others, but also our interpretations of bodily states and our regulation of experiences. And the idea that these interactions might be biased in individuals with chronic pain. So really interesting findings going on there. From all aspects, all the way down from the biological mechanisms up to the social neuroscience. So I now want to move on to really briefly presenting some of the other posters that were related to pain and at the BNF this year. Again, giving really brief overviews and hopefully inspiring just a bit of further reading or some curiosity. So the first poster I'm going to touch on very briefly, because this is by Andrew Palmer, and I know he's present here today, and Andrew will actually be taking the next REM meeting in August, so stay tuned for that in terms of more detail on this study. But really briefly, Andrew is developing a multivariate prediction model to identify prognostic factors associated with pain management outcomes. At the time of the conference, his preliminary predictors had been shown to be higher baseline disability and being married or in a civil partnership. And what Andrew hopes is that these models could be used to optimize treatment allocation and patient outcomes, and also provide insight into the active ingredients of PMPs and offer us guidance on how to ensure structure to maximize effectiveness. As I say, that will be the next REM on the 22nd of August, so stay tuned for more on that one. The next poster I want to cover today is access to treatment and outcomes of chronic pain management in neurodivergent children. And this was an audit done by the Greater Glasgow and Clyde Chronic Pain Clinic between 2013 and 2024. And they found that 7 out of the 751 paediatric patients they saw, 21% were neurodivergent. Interestingly, those neurodivergent patients reported higher rates of hypermobility, family history of chronic pain, adverse childhood experiences, and also disruptions to everyday life as a result of chronic pain. In neurodivergent patients took longer to be referred and had significantly more referrals into that pain service before they were seen. And they also had more referrals elsewhere, so to psychiatry services, psychology services, and outpatient physiotherapy as well. Neurodivergent patients were more likely to be treated with TENS machines, anticonvulsants, psychological therapy, and melatonin. And that was in contrast to neurotypical patients who were more likely to be treated with local anesthetic block and opioids. A really key finding from this audit was that fewer neurodivergent patients had been discharged from the service when they completed this audit. So only 44% of neurodivergent patients had been discharged, compared to 61% of the neurotypical population. And the predominant reason for discharge of neurodivergent patients was non-engagement with the service, contrasting to for neurotypical patients, where the predominant reason was pain improvement. So this audit really highlights some disparities in provision of chronic pain clinics between neurotypical and neurodivergent patients, and highlights a kind of area that needs further investigation. And I know this is an area that we as a team are kind of quite interested in looking at the moment, and hopefully at some point in the future we might be able to produce a similar audit to look at experiences of adults with chronic pain and neurodivergency as well. And the final poster I want to present today is titled Predicting Pain Sensitivity and Persistent Opioid Usage After Major Surgery Using Resting State EEG. Now, as many of us might know, surgery-related opioid exposure is a major initial pathway for long-term opioid use. And so this study is part of an overarching study that's looking to identify factors that contribute to heightened pain sensitivity and persistent opioid use following surgery. Now, the preliminary findings of this study have shown differences in peak alpha frequency. So slower peak alpha frequency is theorized to be associated with higher acute and chronic pain following surgery. And interestingly, post-surgery PAF reduction was shown to be associated with increased likelihood of opioid usage. Additionally, the cognitive profiling of these patients showed that negative interpretation bias was associated with increased pain and opioid use following surgery, and also that increased pain catastrophizing similarly was associated with worse outcomes. So the kind of idea of this study is that pre-surgical EEG, so peak alpha frequency and cognitive profiling, could predict post-surgical pain and opioid dependence, and therefore could identify high-risk patients and reduce opioid dependence in the long term. So some really exciting projects going on there in relation to pain, and yeah, some kind of future directions which are really key to look out for. I want to finally touch on what I consider to be one to watch, which is natural language processing for clinical research. So natural language processing is a form of artificial intelligence that uses machine learning to enable computers to understand human language. And at the BNF this year, there was a company who presented a seminar called Akrivia Health. And they have been using NLP to extract research relevant information from free text NHS patient notes. And this includes diagnosis information, medications, and clinical symptoms. Now, what's really exciting about this is the scale that they can do this on. So they were able to complete an audit of more than 36,000 patients in one afternoon to evaluate the use of a NICE guideline on adherence to treatment protocol for schizophrenia. And even further than that, they then built a prediction model on likely treatments needed by schizophrenic patients, and that was able to be constantly updated with the new data coming in using this AI, natural language processing. So obviously at the moment, all this data is extracted manually, and that can be very time consuming. So very exciting to see that there might be alternatives and more efficient ways of doing this in the future using things like NLP. So definitely want to look out for in the future. And finally today, I just want to reflect on the presence of pain clinicians at a neuroscience conference like the BNF. I think this is a really key thing to think about when you're kind of interacting with the world of academia, which was very heavy at the BNF this year. And the idea that if neuroscientists and clinicians work in isolation, we can get a very fragmented understanding of pain. So it's really, I think, key to realise that neuroscientists can provide us with that biological kind of mechanisms knowledge, and also kind of propose maybe new interventions or new areas to target in terms of chronic pain, but that us as clinicians provide that really key insight into the patient lived experience, which really enriches that research, and also can suggest kind of implementation challenges associated with any of those interventions that the neuroscientists might suggest. And that in order to kind of achieve that transdisciplinary research, we need to really dissolve the boundaries between our disciplines. And I think that having clinician presence at conferences such as the BNF helps to ensure that neuroscience findings are connected to real-world patient experience, and also keeps us as clinicians informed of the latest advances in pain research, which is vital from both sides. So I've actually spoken to the BNA, who hosted the British Neuroscience Festival this year, about writing an insights piece around this theme and around my experience of attending the BNF this year from a clinician's perspective rather than an academic. And one of the things I think I'd really like to highlight in that piece is how any of the developments in pain neuroscience are being interpreted within our frontline NHS setting, and also any reasons why that might be really difficult or kind of difficult to implement any of the information that I've been talking about today in terms of where the neuroscience of pain is at. So if anyone has any feedback on this area or any comments that they want to make, I'd be really keen to hear those, and hopefully to weave them into that insights piece, which I hope will just give the academics that read the BNA a bit of kind of understanding of why it's so important to include clinicians in academic research. So thank you so much, everyone, for listening. And yeah, any feedback, questions, anything? Yeah.
It's fab that. Thank you, Kat. You've obviously got a lot from attending the conference, and you're able to give a fabulous overview there. So thank you. I thought if we just open it out sort of generally, if there's any questions for Kat first of all, and then I think it is worth us coming back to those questions that you posed there. So is there any general questions for Kat? Christian.
Sorry, Kat, thank you very much. That was great. This is a question going right back to the start, actually. Just interested, in the analysis of patients diagnosed with FND.
Yes.
There was quite a lot that were being put forward for outpatient work pre-PMP. Was there any analysis of the reasons for PrEP or a breakdown of disciplines? I'm just interested to know.
I was thinking on the same.
What was going on there?
Yeah, so that wasn't done as part of this audit. But yeah, I agree that it was a really significant proportion that were put forward for PrEP. So definitely something in terms of, I think, future directions, taking forward that audit and using it effectively clinically, of looking into why did so many of those patients need PrEP. But yeah, not done as part of this audit, unfortunately.
No, similar. It just would have been interesting. Wanted to see what percentage of them was linked to anything linked to FND, because presumably a percentage of them just naturally wouldn't be. And just any implications of that. But certainly something interesting to look into in the future.
Definitely.
I was thinking, even though so many had PrEP, quite a high proportion of them still had extra work while they were on the programme as well.
Yeah, really significant kind of support requirements.
And it's not necessarily, I suppose, with the same discipline, though, is it? It might have been they had psych, PrEP, and then physio, ESR, for example, on the programme. So,
definitely.
Alex?
Hi, that was really good. Thanks, Kat. Sorry, my camera's not working today. I was thinking about the other end when you were saying that quite a small proportion actually completed the programme. Sorry if I missed it, but what were the reasons why that number got a little bit smaller? Did they not make it through to PrEP, or did they get paused on the programme?
So actually a lot of the patients were still in active treatment at the time that we completed the audit. And I think that was probably because a lot of their kind of treatment pathways were so long because they had maybe so much PrEP at the beginning. So even though we were kind of looking over this 10-year period, there were 11 patients of the 28 that were put forward for PMP that were still kind of either in PrEP or on a programme or waiting for a programme when we completed that audit. So that's why we only analysed 15 patients that had completely finished.
Okay, thank you.
Yeah.
Do you think as well, even though it was over that, I know over that 10 years, does that suggest as well that perhaps over the last few years we've had an increase in referrals of patients, because we wouldn't have had people obviously on active treatment for so long?
Yes, I agree. I think that there's like a higher proportion, kind of the closer towards the end of the audit period, you definitely see that. And also perhaps just a better recording of the FND diagnosis as well, or people who have now had a diagnosis that perhaps wouldn't have done 10 years ago.
Yeah, because I know we've done quite a bit, haven't we, around the registry to make sure things, all diagnoses are accurately recorded. Okay. Any other questions? I guess we could go to, because I had actually jotted it down, the one around what happens to people who are discharged.
Yes.
Well, no, the question was, what happens when people are unsuitable? And I guess most people were discharged, wasn't it?
Yeah.
But I guess in my mind, when I was listening, I was thinking, are they just discharged, or do we refer people on? Because that's the difficulty with this patient group, isn't it?
I did look in, and there were definitely quite a few who had been referred to, say, for example, the FND group here. But I know that group has like a year-long waiting list. So kind of building on that, I think people were kind of suggesting and asking, well, if they're waiting a year then for FND treatment, is there something that the pain service could be doing in the meantime, kind of thing?
Yeah. And it is difficult, isn't it? Because there's, like I said, there's very limited services that we can refer people onto.
Yeah.
And if anyone's got any thoughts around that, or in their experience. What was your other question?
What I just said, that would there be a role for PMP for patients who had more impactful FND rather than pain symptoms? Yeah.
What are people's thoughts around that sort of? Because I guess one of the things that we're looking at assessment clinic is kind of often screening that out, isn't it? And really only accepting people onto a PMP where the pain primarily impacts on function, and quality of life, as opposed to any other symptoms.
I think it's really difficult to do that sometimes, isn't it? We had a patient this morning with FND who's seen Mike physio for functional physio, but she struggled to progress because of pain. So pain seemed to be the biggest barrier for her. But then seeing her online this morning, you wonder how what's the scope of her progress physically, really, because of the FND. So it's yeah, pain seems to be the biggest barrier, but then again, I think FND was as well for her. So it's quite difficult, really, to pick it out sometimes, isn't it?
Yeah. Is that, and I guess sometimes that's the role sometimes of PrEP, isn't it?
Yeah.
Is
Yeah,
actually
definitely.
thinking, can you engage and can they engage and make progress?
Yeah.
Christian?
Yeah, I was just going to say in relation to that, the other thing is that's where your assessment comes in, because it's about what previous treatment they've had. So does that make sense? Because if they've had a lot of support for FND, then it might be that does that make sense? That actually we still need to give them the PMP treatment. Whereas when we see people for whom they maybe haven't had that level of support, and we think that would benefit them to have that first. So it's not so much about which problems necessarily first or second, but it's also about what's the previous treatment pathway.
Yeah, that makes sense.
Selena's just added something in the chat as well about, do you think we're accepting more towards the latter end of the audit as we're more familiar and confident with FND than what we were 10 years ago?
Yeah, it's a possibility, isn't it? Yeah.
Yeah, there's a few of us we've been in the team about 10 years, and I guess it is something I feel we see more FND patients now than what we did 10 years ago. So I guess that confidence, we are getting more familiar, more confident, and I guess, like you said, we're saying, Christian, there, more confident in what we're assessing for. Okay. Is there any other questions or comments around that? Any questions broader for Kat? Okay, right. Thank you, Kat.
Thank you.
It's a great presentation. Okay.
Thank you.
All enjoy your Friday afternoon and the rest of the weekend.
Thank you.
Okay.
Thanks
very
everyone.
much.
Bye.
Thank
Bye-bye.
you.
Bye everyone. Bye.
Bye.